Hello, everyone. Thank you for joining us today for our webinar entitled Staged for Success, Medicaid Promoting Interoperability Stage 3 in 2019. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Emily Bramblett, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will be posting the presentation slides and a recording of today's webinar on our website, www.mceda.org. Also, the presentation slides are currently available for download in the handout section of your GoToWebinar interface. Today, Bruce will provide you with an overview of the Medicaid Promoting Interoperability Program, reviewing core program rules, eligibility criteria, and 2019 program requirements. From there, Bruce will discuss the Stage 3 objectives and measures, taking a deeper dive into the Health Information Exchange and public health reporting requirements. Finally, he will review the new state requirements for electronic clinical quality measure reporting, provide some links for important program resources, and with any time left, he will address questions posed by the attendees during the broadcast. Please note, the information you will hear in this broadcast is current as of today and is only intended to be a general summary. With that, I will turn things over to Bruce.
Thank you, Emily, and thank you everyone for joining me today to go through the Medicaid Promoting Interoperability Program. So as Emily said, we'll start off with some of the basics. So we'll start off with the name change that happened really early last year, but still kind of plagues folks. Really, it kind of plagues me because CMS, in their infinite wisdom, decided to call 3 different programs promoting interoperability. So it used to be the EHR incentive program. It's always been known as meaningful use, and really that's kind of still the street name of it. So that's the program we're talking about today. This is not to be confused with the quality payment program's MIPS promoting interoperability performance category, or the parallel hospital promoting interoperability program. So the QPP MIPS program is a separate parallel program. So there's a similar name, but now those programs are vastly different, even in terms of that one performance category under the MIPS track. It has undergone some significant changes and looks very little like the Medicaid PI program that we're talking about today. So Medicaid PI will continue for a few more years. We're in it in 2019, we have 2020, and then 2021 is the final year to get any incentives in this program. There are still some significant incentives to be had. So if you have not claimed all 6 of the incentives, then you can still be getting up to $8,500 per provider per year. But you did have to start that program participation no later than the 2016 program year. So you had to join the program and at least claim the very first incentive that's called AIU, or Adopt, Implement, or Upgrade. If you got your foot in the door by either claiming AIU or getting attesting to meaningful use and getting one of those meaningful use incentives, then you can continue and get all the rest of those incentives through the end of 2021. There are no penalties for not participating, though. We did see that earlier along, and that was really back when the Medicare meaningful use program was still up and running as well. The Medicare meaningful use program sunsetted after 2016, and it's now kind of morphed into that MIPS promoting interoperability performance category. But now the Medicaid PI program, this one we're talking about today, is really completely voluntary. There is no penalties for not participating. There are only incentives if you do achieve the program objectives. We are now, as of this year, moving into Stage 3 measures and requirements. You're no longer able to attest to modified Stage 2 after last year. We kind of hung out in Stage 2 for several more years than we really initially planned on or thought we would be. but CMS kept giving us a break and allowing us to stay back in stage 2, which then became modified stage 2. But now, as of this year, we are trudging forward into stage 3, and I'll talk about all of those measures and some of the difficulties we're seeing within them. You also do have to be on your 2015 edition certified EHR technology, otherwise known as CERT. That is mandatory for all program participants now in 2019. You really can't achieve stage 3 without that 2015 certification. There's new functionalities and whatnot that come to you through that new version, your latest and greatest version of your EHR. So hopefully you have been upgraded to 2015 certification. You do have to ensure that you've been upgraded at least to the technology by no later than October 3rd. So we are well into that last 90-day reporting period. And you have to be using that 2015 edition technology for all 90 days of that reporting period. We know that there are still vendors that are attempting to get certified. That might be okay if you are in that boat, as long as your EHR was able to get you upgraded to the version that they're in the process of getting certified by day 1 of your reporting period, and then you have to ensure that your EHR actually receives its certification by the last day of your reporting period. So hopefully you are all upgraded and you're not stuck in that boat where you're still waiting for that certification to come through, but we know there are still some clients out there experiencing that difficulty. Program eligibility, we'll take a look at the provider types. Nothing has changed here over the years, but I like to still review this to kind of keep an eye on who the eligible professionals are. We call them EPs in this program, and really they're just the program participants. They are Michigan Medicaid providers who practice in the state of Michigan and are physicians, which is a very narrow definition of physicians for this group. That's the MDs and DOs. Then we have dentists, optometrists, nurse practitioners, certified nurse midwives, and then physician assistants, as long as they are practicing in what's called a PA-led federally qualified health center or PA-led rural health clinic. From there, once you determine that you are an eligible provider type, if you're one of those EPs, we then kind of go to the next level and look at your Medicaid volume. This is another requirement that has to be met each and every year of the program. If you intend to be a meaningful user, you have to demonstrate that you have a minimum 30% patient volume attributable to encounters with Michigan Medicaid enrolled patients. So it doesn't necessarily mean that you billed Medicaid for that particular visit, but the patient that you saw has to be carrying Medicaid. So for pediatricians, there's an option to meet that at a lower volume at 20%, but just note that you will only receive 2/3 of the incentive payment if you qualify as a pediatrician at that lower percentage at 20%. And also note that mid-level providers do not meet the program's definition of a pediatrician. That can become a sticky point if you're using the group proxy option. I'll talk about that at the end of this slide. But just note that if you have mid-level providers and you're using the group proxy option for eligibility, that will pose a problem. When you're demonstrating that you have that minimum patient volume, you're looking at the eligibility reporting period to measure that the encounters that are attributable to those Michigan Medicaid enrolled patients. That eligibility reporting period is a continuous 90-day period during which you demonstrate that you look at all of the patients seen during that 90-day period, and at least 30% of them, or 20% as a pediatrician, were with Medicaid patients. There's two different time frames that you can use to kind of fish for that continuous 90-day period. We have the prior 12-month option, which is defined as the prior 365 days from the date of attestation. So we're in the program year right now, but the attestation window doesn't open up until early 2020, and it's usually around the first 3 months. So you can log in early 2020 to attest. If you're using the prior 12-month option, it's looking at whatever date you go in to actually enter that data, and you can use any of the 365 days before that. We also have prior calendar year. that option is defined as the calendar year prior to the program year. So looking at an example, when you're testing the program year 2018, it was really the 2017 year. So now that we're in 2019, the prior calendar year would be looking at any time during the calendar year of 2018, where you could pick that. So really, as the year progresses, you end up with almost a 2-year period where you can look for that 90-day eligibility reporting period. I do want to note, though, and this happens every year, clients kind of fall victim to this. There's something called the dead zone. That's what we call it here at MCEDA anyway. These two options, the prior 12 months and prior calendar year, once the attestation window opens, it creates this dead zone of unusable eligibility dates. So for example, if you log in on March 21st of 2020 to get your 2019 attestation in, then 1/1 of 2019 to 3/20 of 2019 is now it's neither in the prior 12-month option nor the prior calendar year option. And so with each passing day of the attestation period, that dead zone grows by a day up until the point where you attest. So just be careful. A lot of folks need to use Q1 as their eligibility reporting period, because we see a lot of Medicaid patients come in for their annual visit during Q1. If you need to use Q1, just be warned that you might run into problems with this dead zone. So if you're planning on using Q1 of 2019, using a 90-day period, make sure that you are, maybe logging in as soon as you can in January to get that data in when that dead zone is very small. Because again, as we get deeper into that first quarter, when we're in 2020 to do that attestation, that dead zone from 2019 is going to grow. So just be aware of that. So then there's two different ways that you can prove that eligibility. You can do it at the individual provider level. So you're just looking at one NPI in your clinic and looking at just their 90-day period and measuring just their patient volume. And then if you have multiple providers, each one can attest with their own eligibility reporting period. And it doesn't matter what the other clinicians in the practice are doing. You could then also use what's called the group encounter data, or the group proxy option. This allows you to look at all of your clinicians all at once with a single same 90-day reporting period. The benefit of doing that could be that you're just running one report instead of 15 different reports. But it also allows you to, since it looks at the entire practice and all of the clinicians all at once, it's a good way to get some low volume clinicians over that 30% hump. If you've got some clinicians that are at 40% volume, and then some of your clinicians are at 20% volume, you can average all of that together, and then everybody is over that 30% mark. So you might find the group proxy option being beneficial to you in that way, and getting your low volume clinicians kind of over that 30% hump so that they can also attest to meaningful use. So in 2019 now, the Medicaid PI program requirements are, again, we're moving into stage 3. Stage 3 has 8 objectives, but within those 8 objectives, there are now 20 associated measures, and you have to provide data on all 20 of them for the most part. There's also a minimum 90-day reporting period here. It is a minimum 90 days, so you're not restricted to only using 90. It can be anything over 90 days as well, and you may find that extending that reporting period is necessary to meet some of the program thresholds. So while you can use any continuous 90 days, you might find that you achieve meaningful use by extending that reporting period to 92 days, or maybe 100 days, or maybe 365 days. Again, it just depends on how when you got those workflows in place and kind of what happened during that reporting period. But don't necessarily limit yourself to only looking at a 90-day period. You can run those different reports to find what works best for you. And most of the time, that 90-day reporting period on the measures is different from the eligibility reporting period. It doesn't have to be. You can use the same 90-day period for your objectives and measures, and your eligibility, but most of the time we see folks using 2 different 90-day periods for that. On top of those objectives and measures, you then have to report on 6 clinically relevant electronic clinical quality measures, or ECQMs. There's a change this year. CMS is undergoing this shift where they're trying to align their different programs in ways that they can anyway. And we did see them make a slight change to the ECQM reporting requirement on this particular program. They're now matching that to the MIPS requirements. So under the quality payment program, the MIPS track there's also quality data that's being reported. They have aligned those requirements and these requirements. So now also under meaningful use, one of them must be an outcome measure. And if no outcome measure is applicable or available, you can flip to high priority measures to report on. And then if no outcome or high priority measures are available, you can report on any 6 clinically relevant ECQMs. So the reporting period might be a little bit different for some of you. Under the quality data, under ECQMs, it is a minimum 90-day reporting period for any first-time attester. So if you have never before achieved meaningful use, you can limit your ECQMs to a 90-day period. You had to have, so AIU doesn't count. A first-time attester is the person for the first time achieving meaningful use. There are very few of those folks out there. I think there's still a few, but the vast majority of meaningful users have achieved meaningful use in a prior year. For all of you who have demonstrated meaningful use in a prior year, it is a full year, 365 days of ECQM data. That is in line with the MIPS track, the quality performance category under the MIPS track. That is also locked in at a full 90 days, or up to 90 days, I'm sorry, a full year, 365 days of reporting. So that same data file that you're using, if you're participating in both programs, you would upload it for MIPS reporting, and then you would also use it here for Medicaid PI reporting as well. There is a new mandate. This was really new to us last year, but some of you might be new to it this year. You do have to submit your quality measures for this program electronically. That is through a new process, a new website called Skimmer. And I'll circle back to that later on slide 27 and give you the details on that. Okay, so we're going to go through, this is the list, the 8 objectives. So from a very high level, I'll kind of talk through these. I'm really going to focus the majority of my time on objectives 7 and 8, the health information exchange and the public health and clinical data registry reporting. There are some nuances there that you need to be aware of to make sure that that you can achieve meaningful use. So here I'm going to pause on this slide and kind of go through a little bit of the first 6 objectives. So objective 1, the protect patient health information. This is your security risk analysis. So if you've achieved meaningful use, or if you're participating in the quality payment program, you're doing these SRAs every year, that's going to continue till the end of time. You either have to conduct or update a prior security risk analysis. I'll note here too that it is not just enough to do your SRA. When you do your SRA, it's going to come back with a corrective action plan, or it should. Nobody gets everything right all of the time. There's often some sort of some issue. It could be minor, it could be major, but most of the time, the vast majority of folks have something that comes out of this SRA, something that they need to correct or fix or get in place. So it's not enough to just do your SRA. You have to be working on your corrective action plan throughout the year as well. If you get audited on this program, the state of Michigan is going to ask for your security risk analysis to prove that you did it. And then they're also going to ask for that corrective action plan. And if you don't have some documentation that you have been working throughout the year on your corrective action plan, you're going to fail that audit. That is a primary way where the folks fail program audits. So don't just do your SRA and then put it on the shelf and dust it off next year to update it or do it again. Make sure that you're working on whatever was identified in that as well. You don't necessarily have to have fixed everything that the SRA demonstrated needed fixing, but you're going to have to at least show that you've been working on it and you've got a plan in place to correct anything that the SRA brought to light. Objective 2, electronic prescribing, that is your ERXs. So this is 60% of all permissible prescriptions are sent electronically. We don't see a lot of folks really struggling with this one anymore. For the most part, ERX is kind of just the way that we do business these days. But the threshold did increase up to 60% now for stage 3. CDS, also, we didn't see any changes going from modified stage 2 into stage 3 here. Looking at your clinical decision support, there are 2 measures here. On measure 1, you're implementing 5 CDS interventions related to 4 or more of your clinical quality measures that you're intending to report on. Again, the same as we've been doing now for several years. And then measure 2 is you have to enable the functionality for drug-drug and drug-allergy interaction checks. Drug-drug and drug-allergy interaction checks are really just hard-coded CDS rules. So really, this objective has you implementing at least 7 different CDS interventions. 5 of them you get to choose from, and then measure 2 picks up the other 2, the drug-drug and drug-allergy interaction checks. You do have to ensure that you have those turned on for the full 90-day reporting period, and you're going to want to grab some sort of screenshots or some proof that those CDS rules were enabled. Don't just rely on your program dashboard. Your EHR really isn't going to be very good at knowing whether all of these 7 CDS rules are turned on or not. Some of the vendors just hard code it and give you a green check mark, whether you've turned them on or not. So that's not going to be enough in the case of an audit. You're going to need to be able to prove through screenshots or in some way, shape, or form. It depends on the CDS rule, but you're going to have some sort of backup proof in your audit file that demonstrates to the state that you did, in fact, have all 7 of these turned on for the full 90-day reporting period. Objective 4, computerized provider order entry, CPOE. Again, we've had this objective for several years. We do see the thresholds increasing for all 3 of the measures. So there's 3 measures contained within CPOE. You have to satisfy, you have to meet the minimum threshold for all 3 of them. Or depends on, I guess it depends on if you claim the exclusions as well. All 3 of them do have exclusions. But measure 1 is more than 60% of your medication orders are follow the CPOE guidelines. Measure 2 is 60% of lab orders, or greater than 60%. And then measure 3 is greater than 60% of your diagnostic imaging orders. So again, CPOE is ensuring that only licensed or credentialed medical staff are entering these med orders, lab orders, and imaging orders. That's really what it's looking at. Credentialed medical assistants are allowed to do the CPOE work as well. They do not have to be certified medical assistants, just credentialed medical assistants. That's a very important distinction. If an MA that has gone through MA school, around me here, we have Ross and Everett and these great schools that are out there credentialing students to go out there in the world and be medical assistants. They're getting some sort of diploma, or they're graduating from that program. Those folks are credentialed medical assistants, and they are allowed to do CPOE. A certified medical assistant is kind of that next level. They obviously also can do CPOE, but you don't have to be certified as a medical assistant to do CPOE. You just have to be credentialed, meaning that you have graduated from an accredited MA school. Objective 5 is patient electronic access to health information. There are 2 measures contained within this, and you have to satisfy the requirements or claim the objectives, or the exclusions, I mean, on both of them. So measure 1 is the patient portal measure that we've had for several years now. It's when this is the one where you're getting credit for providing patient portal access to your patients. The threshold has increased significantly. We're up to now 80% of patients that are given timely access to their information. Timely access under this program is defined as 48 hours. So you're kind of on the hook to get those charts closed out very, very quickly so that that data can then get pushed to the patient portal. I do want to note that that is a different time frame if you are participating in the MIPS promoting interoperability performance category. This same measure is used, but timely access is 4 days. So if you're participating in both programs and running those different dashboards, you could see a different performance rate on this measure, and it might come down to that timely access, where MIPS allows you to take 4 days to get the data there in order to get numerator credit. But on the Medicaid side, it's only 48 hours. So So you're providing that patient access. We do see a change in the way that you're providing that access. So up to this point, it's just been through that patient portal access. They call it, you have to allow them to view, download, and transmit their information. But now there's also this concept of a application programming interface, or API. This is new functionality that comes to you via your 2015 certified EHR. But you have to ensure that you have the API functionality enabled. An API, think of it as really just a backdoor into the same data that you are displaying through your patient portal. API technology is relatively new, but it's this kind of standard way to access that data through a different program. So for instance, if you go to the Apple, the App Store, there are now these programs out there that make use of this API data. So if you're a patient like any other, you are not just seeing one doctor. You are going to your primary care, and you go into a specialist, and maybe 3 or 4 specialists, and each one of those doctors has a patient portal. It's kind of a pain to have to maintain 5 different patient portals and 5 different logins, and you have to, depending on what data you want to access, you have to go to multiple patient portals. An API kind of levels that playing field. By using that API functionality, it allows these patients to use one of these other apps that uses API technology. So the app then uses the API to access that data across all of those patient portals and consolidate it into a single place. This is great technology. Folks are kind of struggling to get it turned on, and you're going to need to work with your vendor and ensure that you have that API functionality turned on, and that you have the ability to communicate how to gain access to your patients. But you are not going to get numerator credit under Measure 1 on this objective until you have that API technology turned on. Measure 2 then is 35% of patients are also provided electronic access to patient-specific education materials. Again, we've had this particular measure now for several years, but the threshold is increased now to 35% are provided access to patient-specific education materials. And we have lost the ability to provide paper copies and get numerator credit. So it has to be electronic access to these materials. In prior years, in modified stage 2, we were able to provide paper copies to these patients and still get credit. That is no longer the case now under stage 3. So it's 35% of patients provided electronic access to those materials. And then measure 6, or objective 6, coordination of care through patient engagement. There are 3 measures within this objective, and I'll talk about each one of them in just a moment. But you only have to meet the requirements for 2 out of the 3. So you can fail to meet the minimum threshold on one of them, and you're still going to meet the overall objective requirements here. So you still have to provide data on all 3 of them, but if you're missing that minimum threshold on one of them and meeting it on the other 2, you're just fine. So measure 1 is patient portal use. So we were just talking about getting patient portal access, and it's a relatively high bar. You have to get at least 80% of your patients, you have to provide them that access. Measure 1 under objective 6 is the one where you have to get a certain percentage of your patients to be using that access, and it is 5%. And we believe that's going to be maintained at 5%. There was, in some prior legislation, we were looking at that percentage moving up. CMS has listened to all of you and your trials and tribulations with getting patients to use this access, so they've kept this one back at 5%. And we believe they're going to keep it there for the remainder of the program. So you have to, 5% of your patients have to use that patient portal access to view, download, or transmit, or access their data via that API technology that we were just talking about as well. So no matter how they're getting that access to their data, you should be getting that numerator credit. The measure 2 is the secure messaging measure. Again, we've had this one for some time. They've maintained that level at 5%. So you have to be sending a secure message to more than 5% of the patients during your 90-day reporting period. And the measure 3 is a new one to us, and it's called patient-generated health data. So in this one, it's the minimum threshold is 5%, but you have to incorporate patient-generated health data from a non-clinical setting. So what is patient-generated health data? So it's some of the data that the patient is generating on their own. There's a kind of a pretty long list of data that would qualify for this. If they're doing home self-monitoring of blood pressures, that data would be patient-generated health data. Patients have access to a wealth of data, like through the wearable technology that's become very popular, the Fitbits and stuff like that. They can be providing some of that data to their clinicians, and that would count. I would really suggest, if you're unfamiliar with that particular measure, grab the specification sheet. Every one of these objectives on your screen right now, the red lettering is a hyperlink that'll take you to the specification sheet for that particular objective. So in your GoToWebinar interface, you can grab the digital copy of these slides. There's a PDF there for you now, and go to this particular slide and click on the objective for number 6 to grab the spec sheet if you want to kind of take a deeper dive into patient-generated health data. Read through that entire spec sheet. There are some interesting sort of wonky things where you don't get credit for this data if they provide it to you during the patient visit. The overall objective of this particular measure for the patient-generated health data is to engage with your patients outside of the regularly scheduled patient visit. So you need those patients to be providing that data on a day that is not the day that they come in to see the clinician. So again, there's some kind of wonky things there on that measure, and I would suggest grabbing that spec sheet to ensure that you understand everything that is required. So objective 7 is the health information exchange, and objective 8 is public health and clinical data register reporting. I'm going to take a deeper dive into each one of these now and finally get off of this slide and move on. So first, we're going to take a deeper dive into objective 7, HIE. So on objective 7, the EP is providing a summary of care record when transitioning or referring their patient to another setting of care, receives or retrieves a summary of care record upon the receipt of a transition or referral, or upon the first patient encounter with a new patient, and incorporates that information from other providers into the EHR. So there's really 3 measures here, and I'm going to kind of unpack each one of these a little bit. So you have to attest to all 3 of these measures, but again, you only have to meet the thresholds for 2 of them. So you could fail to meet the minimum threshold, just like we were talking about on objective 6, where that also had 3 measures, but you have to meet 2 out of 3. It's the same thing here under objective 7. So there are 3 measures. You do have to attest to information, so you're going to be providing numerators and denominators for all 3 of these. But it is okay if you are failing to meet the threshold on them. There are exclusions as well, and I'll talk about those briefly. But just note that if you are, an exclusion doesn't count as one of your 2 out of 3. So if you're claiming an exclusion for one of the measures, that means you have to meet the thresholds for the other 2. You can claim all 3 exclusions as well, and that's just fine. Hopefully you're able to work on these, though. This is some of the most important, impactful work here, and it's really the crux of what we're trying to do, and it's really why we changed the name to Promoting Interoperability. It's all about this health information exchange, and I know there are some significant difficulties with some of these measures as well, and we'll talk a little bit about that. So measure 1 is more than 50% of those transitions of care and referrals. The EP that transitions or refers their patient to another setting of care or provider of care is creating that summary of care record using their EHR and then electronically exchanging that summary of care record with that next provider of care. So we've had that measure for some time now, and we do see that threshold increasing a little bit, up to more than 50% now. So you've got to ensure that any of those outgoing patients, when you're sending them on to another clinician or another setting of care, that for more than half of them, you are creating a summary of care record and electronically exchanging it. Measure 2 then looks at the other side of it, and it is for more than 40% of transitions or referrals received and patient encounters in which the provider has never before encountered the patient, the clinician is incorporating into their EHR that electronic summary of care document. So measure 1 is for the sending of that summary of care. Measure 2 now looks at the other side of it for those incoming transitions. And there's some work you have to do to go out there and try and find that summary of care for any patients coming into your care or any new patients coming to you as well. Measure 3 then is the clinical reconciliation of that data. So for more than 80% of transition or referrals received and patient encounters, any of those brand new patient encounters, the EP is performing clinical information reconciliation. The EP must implement clinical information reconciliation for at least the following 3 data points. You have to be reconciling medications, medication allergies, and the current problem list. And you have to do that for more than 80% of those patients that are coming into your care. So you've got those thresholds there: 50% for measure 1, greater than 40% for 2, greater than 80% for 3. I've got the numerators and denominators, the definitions for those all laid out here. So the denominator for measure 1 is the number of folks that you have sent out, the ones that you're transferring or referring out. Measure 2 looks at the other side of it, and also any of those brand new patients. It is not the billing definition of a new patient, where a patient can be billed out as a new patient if they haven't been seen in 3 years. It's truly just brand new patients you've never seen before. They are included in the denominator for measure 2 as well. So it's any of those incoming patients and brand new patients to your care. And then measure 3, again, is the number of transitions of care referrals during the PI reporting period for which the EP was the recipient or has never before encountered the patient. Then we've got that numerator listed for all 3 of them. So the numerator for measure 1 is the number of transitions of care and referrals in the denominator, where a summary of care record was created using your EHR and exchanged electronically. Measure 2 is the number of patient encounters in the denominator, where an electronic summary of care record received is incorporated by the provider into their EHR. And then measure 3, looking at the number of those patients in the denominator that you have done that minimum clinical information reconciliation of the medication list, medication allergy list, and problem list. We've got some exclusions for each one of these as well. So measure 1, that's the same exclusion we've had for some time now. If you transfer a patient to another setting or refer a patient to another provider less than 100 times during your reporting period, you can claim an exclusion. There is technically a second exclusion here that looks at broadband availability. I've crossed it out because it does not apply. There are actually no counties in the state of Michigan that qualify for this. Same thing under measure 2. I've crossed it out because this exclusion 2 does not exist here in this state. So measure 2 is looking at the other side of it. Again, it's for those incoming patients, but we have a similar exclusion. So for an EP where the total of transitions or referrals received and brand new patients to the practice is fewer than 100, you could claim that exclusion. And then we have the measure 3 exclusion as well. Again, looking at those incoming patients, if it's fewer than 100, you could claim the exclusion there. So under measure 2, because this is really new to us, there's some important things to note. So you have some due diligence here, where for those incoming patients, you have to try and find that summary of care document if you did not automatically get sent one from the referring provider. But if the summary of care is unavailable, you can then delete that patient from the denominator calculation so that you are not harmed, so that your performance rate is not affected, not negatively affected. But you do have to do some due diligence to try and find that summary of care before you can delete that patient and from the denominator by constituting that the summary of care was unavailable. So to do that, you first have to request the electronic summary of care record be sent to you, and then if you did not receive it, you have to either query at least one external source via health information exchange functionality, and so you have to query some sort of external database. There's a lot of services that are coming live right now. You might have heard of Commonwealth or Care Quality. There's some different organizations that are creating these, what is essentially a data lake of summary of care documents. And using your HIE or potentially something that's built right into your EHR, some of the vendors are building this functionality right into their EHRs where you can query care quality or query the Commonwealth service. There's others as well. You have to do that. So you have to query at least one of those external sources via HIE functionality, and then or you have to confirm that HIE functionality supporting that ability to query was not operational in the provider's geographic location and not available within the EP's EHR network. Okay, so you can delete that patient from your denominator if you reached out to the previous provider of care and they didn't send you a summary of care, and if you've queried an external database for that summary of care and also could not find it, you then get to remove that patient from the denominator. But really, for this year, you only have to reach out to the prior provider of care. So we work very closely with the Michigan Medicaid Promoting Interoperability team. I travel to Lansing on a monthly basis to talk with these guys. Great group, but they have determined that for 2019, HIE functionality supporting that ability to query is not operational in this geographic region. So the state is working on providing you that ability. There is a new service. We are also working with MyHIN on a great new product called Mitigate that will come live in early 2020. It will be a free option. It's going to allow you to log in to this website called Mitigate, where you can tap into MyHIN's data lake of summaries of care. So it is not ready yet, and as such, the state of Michigan has determined that they're not going to hold clinicians to querying that external database. Some of you have it built into your EHR already. I know some vendors like ECW are offering that ability through their connection to the Commonwealth network. So if you have reached out to that previous provider of care and they couldn't do it, that's really all you have to do, unless you have gained that ability within your EHR to query it. Go ahead and do that. And if you also then can't find that summary of care, you can delete that patient from the denominator. So that is only for 2019, where you don't have to query that external database. When this becomes live, Mitigate becomes live in early 2020, you'll also be mandated to take that step as well. Some additional information on this particular objective. So for measure 2, a record cannot be considered incorporated if it is discarded without the reconciliation of clinical information, or if it is stored in a manner that is not accessible to the EP for use within the EHR. So CMS does not strictly define incorporate. They've kind of left that, for now anyway, they've left that up to you to figure out. They didn't want to define how you are saving that document because there are a wealth of technological barriers here. So you don't have to, you have to have access to the electronic summary of care document, but you don't have to save it in that electronic form in your EHR. If you want to convert it to a PDF or something like that and then save that document to the EHR, that would also be called incorporate. And we see the vendors doing lots of different things. The vendors are really struggling to get this measure right. It is a very difficult measure to program, and the vendors we're working with a few of them to kind of talk through it and get it right. We see the vendors doing some pretty wonky things with this measure. So just be careful, talk to your vendor, really understand the workflow so you can understand how you can do that due diligence and then delete those patients from the denominator. That's an important part of meeting this threshold, I think, this year, because there are so many wonky things out there that are happening. Really take a close look at how your vendor is giving you numerator credit for measure 2. And understand that workflow and make sure that you're doing what you need to get that proper numerator credit. For measure 3, the process, that's that clinical reconciliation, that may include both automated and manual reconciliation to allow the receiving EP to work with both the electronic data provided and to work directly with the patient to reconcile their health information. So the clinical reconciliation for measure 3, do it however you can with whatever data you have, and you're going to get that numerator credit. It does not have to be electronic clinical reconciliation. And also for measure 3, if no update is necessary, the process of reconciliation may consist of simply verifying that fact or reviewing a record received on referral and determining that that the information is fine, that you didn't need to do any update. You should be getting that numerator credit for that as well. And then really anybody in the practice can conduct clinical reconciliation, including non-medical staff, but as long as they are doing so under the direction of the EP and that either the clinician or the credentialed medical staff is responsible and accountable for the review of that information. So really anybody in the clinic can be doing that clinical reconciliation and getting numerator credit as long as there's a credentialed medical staff, whether it's the EP or the nurse or the MA, somebody is taking a look at that information and making sure that they're taking any relevant action to any of that data. Okay, let's roll forward into Objective 8, Public Health and Clinical Data Registry Reporting. So here you have to be in active engagement with a public health agency or clinical data registry to submit electronic data in a meaningful way using your EHR. So you have to actively engage with a minimum of 2 registries. And you can use the same measure twice. For instance, we have some folks that we work with that practice on the Michigan-Ohio border, and they see patients coming from both states. So some of those clinicians will connect to MICR, Michigan's immunization registry, but then they may also connect to Ohio's because that's relevant to their Ohio patients. They could then attest to measure 1 twice, and they would meet this particular objective. So any one of these measures can be used more than once. And we see some folks, a lot of folks really using measure 3 or measure 4 twice as well. So in measure, I'm going to take a deeper dive into each one of these, but measure 1 is the immunization registry, measure 2 is syndromic surveillance, measure 3 is electronic case reporting, measure 4 is public health registry reporting, and measure 5 is clinical data registry reporting. So what does it mean to be actively engaged? So there are 3 different options for active engagement. Any one of these is enough to meet the measure's requirements for that registry for 2019. So you don't have to get all the way to option 3. Any one of these would work. So option 1 is you've completed registration to submit data. So you've kind of thrown your hat in the ring with that registry, saying that you've kind of begun that onboarding process. You've given them a registration for it. That, if you are going to sit in option 1, if you're planning to attest to only being in option 1 for a particular registry for this year, you do have to ensure that you have done that registration within the first 60 days of your EHR reporting period. If you register for MICR on the 61st day of your reporting period, and you're only going to be in that registration state, you can't claim option 1. So you got to make sure that you have completed that registration within 60 days. That's the only option that has that requirement, and really it's so that folks can't kind of game the system and throw a registration at a registry on day 89 and claim to have met the program requirements. That's why they put that 60-day requirement in for option 1. If you're able to roll forward into testing and validation with the registry, it doesn't matter when you started to engage with them. So if you get into testing and validation, option 2, that means you're somewhere in that process where whether it's you or your EHR vendor are working with the registry to kind of work out what that data transmission looks like. There's very specific requirements for what the data needs to look like. And if you're in that process of sending test messages and working with the vendor, working with the registry, then you are somewhere in option 2, testing and validation. If you've completed that process and you are sending live production data, where you're done all that testing and validation, and now you're in production, you're in option 3. Okay, let's take a little bit deeper dive into each one of the measure options. Measure 1 being immunization registry reporting. There is a new requirement here. So many of you have been working with MICR for years now and have been claiming active engagement in measure 1. Just note that it is not, up to this point, you've been submitting immunization data, but now it is a bidirectional interface that is required. You have to also be able to receive immunization forecasts. That is a requirement. So a unidirectional production feed is no longer valid. You have to at least be actively engaged with MICR for their bidirectional interface to be able to claim active engagement in this measure this year. There is an exclusion for any clinician that does not administer any immunization. There are technically 2 other exclusions that are written out, but I've crossed them out again because they do not apply to our state. So again, in Michigan, we have MICR, the Michigan Care Improvement Registry, and you must be actively engaged for their bidirectional connection. It is called QBP, or Query by Parameter. So that unidirectional active engagement in any option in a prior year no longer meets program requirements. So if you have not at least thrown your hat in the ring for QBP with MICR, you are no longer actively engaged with the immunization registry, and you would not be able to attest to this measure. So MICR does require participants to be in production with their unidirectional feed, that's called XV or VXU, prior to accepting registration for QBP. So there's to register, you're just going to send an email request to the email address in that last bullet there on your screen. That is enough to claim active engagement option 1. But if you have not achieved production with MICR for VXU, they're going to reject that registration. It is a requirement of that MICR has that you must be in production with VXU in order to engage with them for QBP. But for 2019 only, the state is going to accept your documentation of that registration attempt as active engagement option 1. So there are a lot of you that are still struggling to get up and running and get all the way into production for VXU. There's some of you have been dragging your feet and not wanting to do it for various reasons. Some of you have hit technology barriers that have prevented you from getting into production. It's very important that you are working with MICR through whatever struggles you have to get into production. The state's going to allow those folks that did not get into production with VXU to still claim active engagement option 1 with MICR if you have at least sent in that registration. But just note that MICR is going to reject that registration if you did not achieve production yet under their unidirectional feed. But for now, anyway, for the remainder of this year, the state's going to accept that documentation of registration attempt as active engagement option 1. That will not be the case next year. So if you intend to use this measure in 2020, you've got to ensure that you are in production with VXU. Otherwise, the state will not accept your active engagement for QBP. Syndromic surveillance reporting doesn't apply to very many folks. So you have to be, if you're attesting yes to being in active engagement with what is the Michigan Syndromic Surveillance System here in Michigan. There is only one exclusion that applies, although it does apply to the vast majority of clinicians in our state, because the Michigan Syndromic Surveillance only accepts data from hospital, ERs, and urgent care locations. So if you are not a hospital, ER, or urgent care location, you cannot onboard with this particular registry. And there are a lot of primary care offices that kind of become urgent care-like in the after hours. That does not count. It has to be in a legitimate urgent care location to qualify. So again, the vast majority of clinicians qualify for the exclusion on this one. Electronic case reporting, again, kind of similarly, the vast majority of clinicians would qualify for the exclusion on electronic case reporting. And again, you would claim that exclusion for a couple of different reasons, really. One of them is written out here on your screen. If the clinician does not treat or diagnose any reportable diseases for which data is collected by our jurisdiction's reportable disease system. So in Michigan, that's called the Michigan Disease Surveillance System, or MDSS. The link here will give you the laundry list of data that MDSS is looking for. See if you have any of those reportable conditions. You can click on this link here. But there's also a standardized format that has been developed. So your EHR has to be certified for electronic case reporting. There's a very specific, much like we saw under immunization registries years ago, and we see for cancer registry as well, there is a very specific standard that must be met to be able to do electronic case reporting. And your EHR has to be certified to that standard. And actually, very few EHRs today have gone forward and gotten certified for this particular standard. So there's some more information here. You can click on this link that'll give you information. But really, the translation here is, if your EHR is not certified for electronic case reporting, the EP cannot use this measure. You might reach out to MDSS because you have one of these reportable conditions in this link here, but MDSS is going to ask you what EHR you're on. And if your EHR is not certified, they're going to reject that registration. So you have to have a reportable condition, and your EHR has to be certified to the electronic case reporting standard, which very few of them are. So the vast majority of clinicians would qualify for an exclusion here. Before I get to the next two, I want to pause because we saw a significant change between modified stage 2 and stage 3 with the specialized registry reporting. So we used to have a measure called specialized registry reporting. That is no longer one of the measures, but all of those specialized registries are going to map either to a public health registry or a clinical data registry now. So, and really it just depends on whether it is administered by a governmental entity, which case it is now a public health registry, or if it is a non-governmental agency or entity that is administering it, then it would be a CDR, a clinical data registry. So public health registry reporting, you're going to be actively engaged with a PHA. While there are exclusions listed, really nobody in the state of Michigan qualifies for an exclusion on this particular measure. The reason for that is due to jurisdiction. So I'll kind of talk this through. Jurisdiction is actually, it isn't just looking at the state of Michigan. It's looking at the jurisdiction of the registry, and which some of these are national. For instance, I have it down here at the bottom. We have the CDC National Healthcare Surveys Registry. This is a registry that every single clinician type qualifies to connect to, and it is a national registry. Therefore, nobody can claim any one of these exclusions because everybody in the state of Michigan qualifies at least for the CDC's registry. So I've crossed out all of the exclusions now on this slide because nobody technically qualifies for this measure exclusion. In Michigan, we've got some great registries that you can connect to. The MAPS, the Cancer Registry, Birth Defects Registry, the Birth Registry, and the Newborn Screening. Note that Michigan's Dental Registry, called MITRE, cannot be used in the Medicaid PI program. And that is because it does not use a valid specified standard for data transmission. I'm going to talk about that in just a couple of slides too. And then similar to the electronic case reporting, if your EHR is not certified for cancer reporting, you cannot engage with that particular registry. Clinical data registry reporting then is looking at the flip side of all of those different registries. A lot of them used to be called specialized registries. They're now clinical data registries. But you have to, you can become actively engaged with one of them. There are a ton of them out there. There are exclusions, but again, note that jurisdiction is often national with these different CDRs. For almost all of them, they are national in their jurisdiction. We've got the Prime Registry as one example of many. If you want to look for additional examples, click on this link to the National Institutes of Health list of registries. This is not a comprehensive list. There are hundreds of different CDRs out there. In the interest of time, I'm going to roll on. Potential issue with the former specialized registries. So this is what I was just getting to. There's some new language that's come to us for the Medicaid PI program. This does not apply if you're in the MIPS program. But really, there's the actual language here, but I'm going to look at the translations. So through all of this, really, it's just getting at these specified standards that must be used. So these different registries have to be using a specified standard, meaning there's lots of them out there from, could be HL7, QRDA, there's a CCDA, there are these different standardized transmission standards that are out there, and these registries have to be using one of those. So for Measure 4, if the registry is a public health registry, does not use a standardized language for the transmission of data, and you did not attest to being in active engagement option 3, production, in a prior program year, you can't use it this year to meet stage 3 requirements. And the translation for Measure 5 is if it is a CDR and does not use a standardized method or language for the transmission of data, it can't be used in this program. So I'm going to flip to the next slide. That's a lot of text that doesn't make a lot of sense to a lot of folks. So we worked with the state to come up with this, this decision tree to kind of make sense of it. This is what the state will be using this year to validate the different registries. They're first going to look at whether it's a public health registry or a CDR. So we'll go down the left side of this first. If it is a governmental entity, that could be one of the state's registries. It could be that CDC, National Health Registries we talked about. The first question is, are specified standards being used for the data transmission? If the answer is yes, all is well. If the answer is no, then they're gonna ask, has the EP achieved production status in a prior program year? If the answer is yes, all is well. If the answer is no, you can't use that registry. It gets a little simpler on the other side for CDR. It takes this part of it out. So again, they're going to ask, are specified standards being used for the data transmission? If the answer is no, it simply can't be used. If the answer is yes, then it can be used for stage 3. This is a list of the state's registries that they have, and links to some more information on each of them. So what must a program participant do prior to claiming a public health measure exclusion? At a minimum, clinician needs to determine if the registry is offered by a PHA in their jurisdiction, which again, be careful, that could be state or national level, depending on the registry, is relevant to the provider's scope of practice. You can look at the slide we were just on for the states. Again, one example of a national level PHA is the CDC, National Healthcare Surveys. If it's clinically relevant and you're technologically capable of onboarding with them, you have to achieve active engagement. Then you can, so once you get through the state's options or the state or even national level PHAs, you can determine if a medical society with which the provider is affiliated endorses or sponsors a valid registry. If it does, you have to engage with that registry. And if through steps 1 and 2 you can't find any registries that work for you, you can claim an exclusion for one or even perhaps both. But be careful, claiming an exclusion does not necessarily count as one of your 2 registries that you have to onboard for. So an exclusion does not count towards one of the 2 unless you can exclude from so many of those measures that there's fewer than 2 available. So let's say you can immunize, or let's say no. Let's say you don't immunize, so measure 1 doesn't count. Everybody qualifies for one of the the public health, so everybody qualifies for that CDR. But if there's nothing else that is clinically relevant to you, you're excluding from all the other measures, then just that one onboarding with the CDC would be enough to meet that objective. But just be careful, exclusions don't always count towards one of your 2. Skimmer, again, we talked about the electronic submission requirements. So you do have to at least attempt to submit your quality measures through this new system. It is a requirement to connect with Skimmer. It kind of phases out the manual submission process. There's some links here that can kind of get you through it, but just note that you don't have to, you have to at least try to submit through Skimmer. It's a relatively simple process. The state has worked with MyHIN to build a really kind of user-friendly system here. But if you cannot submit your ECQMs through Skimmer, you can send an email to the state of Michigan and kind of explain why you haven't been able to, and then they're going to enable the ability to manually attest to that data again, just like we have had in prior years. I've got some resources here. There's a whole laundry list of great information here for you, a lot of it that I've kind of touched on. I've kind of marked off 2 here as being most important. MCEDA we've recently developed some stage 3 measure tip sheets that kind of give you some of the high-level information that you need on all of the different measures for stage 3. So I would encourage you to go to this link here and grab our new stage 3 tip sheets. Find some great information there, kind of help you navigate the ins and outs of these different measures. And then if nothing else, grab the EP guide to the Medicaid PI program. It's a fairly lengthy document, but it is packed full of really great, important information, a lot of which I've already talked about here. And then there is information related to the skimmer process and the link to the skimmer website here as well. And I've gone a couple of minutes over. I had a couple of questions, but the person that posed them has since bowed out. I'm sure she had something else important to do at 1 o'clock. But if you have any questions for me going forward, please don't hesitate to reach out. We are still supporting clinicians with state dollars here. The state of Michigan is funding us to be out here helping you with this process. Stage 3 is a beast. It is very difficult to achieve. Just because you have met meaningful use in prior years does not mean you're going to achieve it now under stage 3. These the new measures and the increased thresholds have created some pretty big barriers for folks. So just know that you are not alone in your struggles. If we can help you, please give us a call. For only $200 per clinician, we're going to assign one of my colleagues to you who is going to work tirelessly with you and your vendor to get you to meaningful use. We have a vested interest in that regard for you to be a meaningful user. The state of Michigan is funding the vast majority of what it costs to have us there in your office, but we don't get paid unless you achieve meaningful use. So we are going to fall over ourselves. We're going to do everything we possibly can to get you to meaningful use. So give us a call, shoot us an email, and connect with us if you are struggling with this. And if you have any questions moving forward, feel free to reach out to me. Got my email address there, my phone number. I am happy to help with any questions you might have. With that, I thank you so much for sticking with me through all of this. I look forward to seeing you on a future broadcast. I hope you have a wonderful day.